Usually when we talk about a medical diagnosis, there is this inherent expectation of precision.
Right. Yeah, it feels very structural.
Exactly. Almost like engineering. Like if someone falls off a ladder and breaks their arm, the radiograph goes up on the screen and the bone shows this jagged, undeniable white line.
And the clinician just points right to it.
Yeah, the diagnosis is just right there in the open.
It's binary. And, from a clinical perspective, that binary nature is incredibly comforting.
Oh, absolutely.
The pathology is visible, it's easily categorized, and the intervention, setting the bone, casting it, it's immediately apparent. We are naturally drawn to diseases that announce themselves clearly.
But the moment you step into the world of chronic internal medicine, and specifically the global public health landscape of the human liver, that reliable X-ray machine just completely shatters.
It really does.
The diagnostic landscape we are looking at today is completely murky. It defies that immediate, visible categorization.
And that is the defining challenge of hepatology and global public health.
Yeah.
To truly grasp the magnitude of chronic liver disease, you have to fundamentally shift your perspective away from acute, visible trauma.
Because it's not a sudden break.
Exactly. You have to move toward understanding slow, invisible, structural degradation.
And that is exactly what we are doing in today's deep dive. So whether you are a medical student trying to make sense of your immunology and pathology blocks, or maybe a junior doctor currently doing rounds on the gastro ward.
Or a public health trainee looking at population-level epidemiology.
Right. Whoever you are, we have a massive conceptual exploration ahead of us. We are using the foundational frameworks from the Oxford textbook of Global Public Health as our guide today.
Specifically focusing on Chapter 8.16, the agents of chronic hepatitis.
But before we get into the virology and the biochemistry, I want to establish a mental model for you.
A structural spine for the whole discussion.
Yeah. I want you to imagine the human liver not just as an organ, but as a massive, bustling city's central water treatment and logistics plant.
I love that analogy. It is the ultimate biological infrastructure.
It really is doing everything.
Right. I mean, the liver is synthesizing the crucial proteins that keep the traffic flowing, like albumin, which maintains osmotic pressure.
And the coagulation cascade factors, right? The things that stop us from bleeding out.
Exactly. Plus, it manages the city's energy reserves by storing glycogen. And crucially, it filters the constant influx of toxins arriving from the gastrointestinal tract.
It takes a beating.
Oh, it can take a staggering amount of punishment and still keep the city functioning.
Which brings us to the core problem. Chronic liver disease is not a wrecking ball.
No, it's not.
A wrecking ball is acute liver failure, like Tylenol toxicity or a sudden catastrophic event. Chronic liver disease is silent rust.
Silent rust, that perfectly captures it.
You don't see the rust day to day.
Huh?
The city's water keeps flowing, people commute. But over decades, 20, 30, 40 years, that rust is steadily degrading the steel beams underneath the entire metropolis.
Until it just gives out.
Yeah. Seemingly out of nowhere, on a Tuesday afternoon, the bridge collapses.
And in clinical terms, that SOAR collapse is decompensated cirrhosis.
Or the development of hepatocellular carcinoma, liver cancer.
Right. That metaphor perfectly encapsulates the hazard we are discussing today. The silent rust is the long-term fibrotic scarring of the liver tissue.
So our mission today is to map out the exact mechanisms of that rust. We are going to examine viral hepatitis B, D, and C.
And then we'll pivot to the metabolic drivers: alcoholic liver disease and non-alcoholic fatty liver disease.
Okay, let's unpack this. We're going to build a logical three-line here. Risk, leading to exposure, leading to outcome, leading to intervention, and finally, system impact.
Because we aren't just memorizing facts today.
Definitely not. We are looking for the underlying patterns. Because if we can understand the why, like why a virus acts a certain way or why the immune system responds as it does,
then what becomes infinitely easier to remember and apply.
Exactly.
And that systems thinking approach is just so vital. The biological mechanism of how a specific pathogen replicates dictates the clinical outcome for the patient, which in turn completely dictates the public health strategy required to manage it at a population level.
You cannot separate the molecular biology from the global health policy.
You really can't.
So let's start analyzing the first major architect of this silent rust, hepatitis B.
Let's do it.
Looking at the etiology, we are dealing with a member of the Hepataviridae family. It is a double-stranded DNA virus.
But the detail that is absolutely staggering here is its physical size.
It's tiny.
It's incredibly small. It has the smallest genome of all replication-competent animal DNA viruses. We are talking about roughly 3,200 base pairs.
Wow. And for context, the human genome is over 3 billion.
Right. And this virus gets by with just 4 major genes. S for the surface envelope, C for the core antigen, P for the viral polymerase, and X.
And the X acts as a transcriptional transactivator, right?
Exactly. It represents a terrifying masterclass in evolutionary efficiency.
How does it even function with only 4 genes?
Well, to survive with that microscopic toolkit, the hepatitis B virus utilizes overlapping reading frames.
Okay, what does that mean in practice?
It means it reads the same sequence of DNA from different starting points to produce completely different proteins.
That is just brilliant, honestly.
It is. And with just that tiny, highly efficient machine, it has managed to leave an incomprehensible footprint on human history.
Yeah, epidemiologically, the numbers are wild. It is estimated that historically around 2 billion people have been infected worldwide.
Yeah, 2 billion.
I just want you, the listener, to pause on that number for a second. 2 billion people. That is roughly a quarter of the entire human population that has encountered this tiny strand of DNA.
And out of those 2 billion, over 240 million people are currently chronic carriers.
Meaning they are walking around with the virus actively replicating in their liver right now.
Yes. And the World Health Organization looks at this global burden and classifies endemicity into 3 specific tiers.
Based on the prevalence of the hepatitis B surface antigen, right, the HBsAg.
Correct. You have high endemicity areas where 8% or more of the population are carriers. Intermediate endemicity is between 2 and 7%. And low endemicity is less than 2%.
And that distribution is incredibly regional, isn't it? The genetic variants, the genotypes, map almost perfectly onto human geography.
They really do. We look at genotypes A through H, with I and J being more recently identified.
And they show distinct patterns, like genotype A is heavily concentrated in sub-Saharan Africa and Northern Europe.
Right. While B and C dominate the Asian continent.
And D is prevalent throughout the Mediterranean and parts of India. It functions almost like a molecular fossil record of human migration.
It's fascinating.
It is. But I want to pivot to the actual pathology here, because there is a profound paradox at the heart of hepatitis B.
The clinical presentation.
Yeah, this tiny, hyper-efficient machine enters the liver, but it doesn't actually destroy the liver cells.
Right. The pathogenesis of hepatitis B is highly counterintuitive. The virus itself is fundamentally not directly cytopathic.
Which is weird, because when we think of viral infections like Ebola or even a severe influenza,
we picture the virus invading a cell, hijacking the machinery, replicating violently, and then just bursting the cell open to release the new virions.
yeah, total destruction. But hepatitis B doesn't do that.
No. It is perfectly content to enter a hepatocyte, quietly use the cell's resources to build more of itself, and export those new copies without killing the host cell.
So if the virus isn't the thing destroying the hepatocytes, then what is causing the rust? Why you patients end up with cirrhosis?
The destruction is entirely friendly fire.
Friendly fire.
Yes. It is caused by the host's own immune system. To understand this, we have to look at the interaction between the virus and our cytotoxic T cells.
The immune system's assassins.
Exactly. This interaction defines the clinical course of the disease, and it forces us to differentiate between 2 critical phases.
The immunotolerant phase and the immune clearance phase.
Right. And the single most important variable determining which phase you enter and how long you stay there is the age at which you were first exposed to the virus.
This is such a crucial concept. Let's build a clinical scenario to illustrate this for a listener.
Okay, imagine a neonate infected by their mother during childbirth.
So perinatal transmission, which is highly common in those high endemicity regions we mentioned.
Exactly. That newborn baby's immune system is immature. It is still learning to distinguish between self and foreign.
Right, it's just coming online.
So the baby's liver gets infected with hepatitis B, and the virus starts producing massive amounts of viral DNA and a specific protein called the E antigen.
HPV.
Right. The baby's immune system surveys the liver, sees these viral proteins everywhere, and essentially concludes, well, this must just be part of our normal biology. I will leave it alone.
Wow. So the alarm bells are completely silenced. The immune system is effectively blindfolded to the infection.
That is the immunotolerant phase. Clinically, if you take blood from that child, you will see a sky-high viral load.
Millions of copies.
Millions, but their ALT levels, the alanine aminotransferase.
The enzyme that leaks into the blood when liver cells die.
Right, those ALT levels will be perfectly normal. There is zero inflammation, because no liver cells are dying. The virus is replicating peacefully.
To use our metaphor, the water supply is absolutely flooded with the pathogen, but there is zero rust forming on the pipes. The city is structurally intact.
But biology rarely stays static. Eventually, and in the case of perinatal infection, this might take 20, 30, or 40 years.
Wow, decades.
Decades. Eventually, the immune system matures and finally wakes up. It suddenly recognizes those viral proteins as foreign invaders and mounts a furious delayed attack.
It sends in the cytotoxic T cells.
Yes, it sends them in to destroy the infected hepatocytes. This is the immune clearance phase.
And that is when the clinical picture turns chaotic. The ALT levels spike because the liver cells are being slaughtered by the T cells.
Massive necroinflammation takes over.
And as the liver desperately tries to heal that widespread damage, it lays down collagen. It forms scar tissue. That is the fibrosis.
And that delayed realization perfectly explains the chronicity rates.
Because it entrenched itself for so long?
Yeah. Exactly. If you acquire hepatitis B perinatally, you have a 70 to 90% chance of developing a chronic, lifelong infection.
Your body just tolerates it for too long.
Right. Conversely, if you are exposed as a healthy adult, say through an unprotected sexual encounter or a contaminated needle,
your fully developed immune system immediately recognizes the threat.
yes, you might develop acute symptomatic hepatitis, you might turn yellow with jaundice, but your immune system fights the battle and wins. Adult exposure results in over 95% clearance of the virus.
So the age of exposure dictates the entire trajectory. And that immunological battle leaves a very specific paper trail in the blood, which dictates our diagnostic approach.
We rely heavily on those serological markers.
Right. The surface antigen, HBsAg, is the primary marker. If that is positive, the virus is currently present.
But if the immune system wins that battle, we see the development of anti-HBs.
The antibody to the surface antigen.
Exactly. That is the marker of resolution and lasting immunity.
We also look closely at the E antigen, HBAg, which acts as a proxy for high viral replication and infectivity.
But underneath all these circulating markers, there's a molecular mechanism that makes hepatitis B exceptionally dangerous.
The thing that makes a true, definitive cure almost scientifically impossible right now.
Yes.
You were talking about cccDNA, covalently closed circular DNA.
That's the one.
Explain how this works, because it seems like the ultimate viral contingency plan.
It absolutely is. When the hepatitis B virus enters a liver cell, it travels directly into the nucleus.
Right into the vault.
Right into the vault. Once inside, its genetic material is converted into a highly stable, tightly coiled circular piece of DNA, the cccDNA.
And it just sits there.
It embeds itself in the host's nucleus and acts like a tiny autonomous mini chromosome. It serves as the permanent template for all future viral replication.
So even if the patient's immune system, or our modern antiviral drugs, successfully clear out every single circulating viral particle in the bloodstream,
that cccDNA remains physically archived inside the nucleus of the hepatocytes.
Man. So if the patient's immune system ever drops its guard, say, they undergo chemotherapy years later, or receive immunosuppressants for a transplant,
that cccDNA wakes up, restarts the replication factory, and the infection flares up all over again.
creating a state of occult or hidden HBV infection.
Precisely.
This brings me to a clinical question. If the T cells are the ones destroying the liver, and the virus is hiding in the nucleus, how do our pharmacological interventions actually work?
It's a great question because the approaches are very different.
Right, I am looking at the difference between treating a patient with nucleoside or nucleotide analogs, drugs like entecavir or tenofovir, versus the older treatment of pegylated interferon. They seem to operate on completely different philosophies of warfare.
They do. Interferon therapy is essentially systemic immunomodulation.
Meaning you are ramping up the immune system.
Exactly. You are injecting a powerful signaling protein that yells at the patient's immune system to wake up, become highly aggressive, and attack the virus.
You are artificially inducing a massive immune clearance phase.
Yes, it involves a defined treatment course, typically 48 weeks, and the goal is to force a loss of the surface antigen.
But the collateral damage is severe, right?
Terrible. The patient experiences horrible flu-like symptoms, depression, and profound fatigue for a year.
Because you are inducing the inflammation intentionally to force the body to clear the infection.
Exactly. The nucleoside and nucleotide analogs, however, take a stealthier approach.
Entecavir and tenofovir.
Right. They are structural decoys. They look like the building blocks the viral polymerase needs to copy its DNA.
Oh, I see. So when the virus tries to incorporate the drug into its new DNA chain,
Replication halts. They are potent viral suppressors. By dropping the viral load so drastically, the immune system no longer sees a massive threat.
the T cells calm down.
The inflammation stops. The rust stops forming.
But because of the cccDNA hidden in the nucleus, the analogs aren't killing the source code. They are just jamming the factory assembly line.
That is the caveat. If you stop the tenofovir or tenofovir, the cccDNA immediately resumes production and the viral load rebounds.
Therefore, analog therapy is generally an indefinite, lifelong commitment.
We are managing the disease, not curing it.
And when you are dealing with a disease that cannot be easily cured, the absolute mandate of public health must shift to prevention.
We have to look at the system impact.
And the story of the Universal Infant Immunization Program for Hepatitis B is arguably one of the most spectacular triumphs in the history of global medicine.
It really is. It is routinely described as the first anti-cancer vaccine ever deployed.
The logic is undeniable, right? By preventing the chronic viral infection, you completely eliminate the cascade of inflammation and cirrhosis that leads to hepatocellular carcinoma.
And the population-level data is just beautiful. Look at Taiwan.
Yeah, the text mentions they were one of the first to implement universal vaccination.
And their childhood prevalence of the surface antigen plummeted from an endemic 9.8% down to a negligible 0.7%.
That's incredible. And in indigenous Alaska Native populations, aggressive vaccination campaigns dropped the prevalence from 3.2% down to absolute zero in children under the age of 10.
Absolute zero. It is the definition of upstream engineering.
We are installing a security perimeter at the city gates so the vandals never get inside to start degrading the infrastructure.
Exactly. And the modeling emphasizes the importance of timing here.
Right. Infant immunization alone prevents a massive 75% of global deaths from HBV-related causes.
But if health systems manage to administer a birth dose, giving that first shot within 24 hours of delivery, you interrupt that high-risk perinatal transmission window.
The immunotolerant window we talked about.
Yes. Adding that birth dose pushes the prevention of global HBV-related deaths up to 84%.
Delivering a vaccine within 24 hours of birth in resource-limited rural settings, that is a profound logistical challenge.
It is. It involves complex cold chain storage and healthcare access. But the epidemiological payoff makes it one of the most cost-effective interventions in medicine.
Okay, so we've established hepatitis B as a standalone, highly efficient pathogen.
Yeah.
But biological systems are opportunistic.
They are.
What happens when this efficient virus picks up a dangerous hitchhiker? Let's move our focus to hepatitis D.
Hepatitis D, or the Delta agent. It is an absolute anomaly in human biology.
How so?
Well, it sits on the boundary of what we even consider a virus. It is a transmissible pathogen consisting of a tiny, single-stranded RNA genome.
It's just a scrap of genetic material.
Yeah, it more closely resembles the viroids that infect agricultural plants than a human virus. And it has a fatal defining flaw.
Which is?
It is structurally incomplete. It cannot replicate its full viral particle or assemble an outer envelope on its own.
So it requires a host. But not just a human host.
Yeah.
It requires another viral host.
Exactly. It specifically obligately requires the envelope proteins of the hepatitis B virus. The HBsAg, it uses the host cell's RNA polymerase in a unique rolling circle replication mechanism to copy its genetic material.
But it's completely trapped inside the hepatocyte unless hepatitis B is actively manufacturing surface proteins that it can steal to package itself and exit the cell.
Yeah.
I picture it like a carjacker who doesn't know how to hotwire or build a car. They have to wait in the factory until hepatitis B finishes building the vehicle, and then they hijack it right off the assembly line.
That is a highly accurate way to visualize the molecular dependency.
That's crazy.
And because of this unique dynamic, the clinical presentation of hepatitis D is entirely dependent on the timing of the infection.
So we separate this into two distinct clinical frameworks, co-infection and superinfection.
Let's unpack the difference because the long-term prognosis for the patient is vastly different.
Right.
A co-infection occurs when an individual is exposed to both hepatitis B and hepatitis D simultaneously.
For example, through a shared contaminated needle.
Right. The patient's immune system is naive to both pathogens. The resulting acute illness is often violent.
Because it's a double hit.
Exactly. The patient has a significantly higher risk of developing severe acute hepatitis or even fulminant liver failure compared to HBV alone.
It's an overwhelming dual assault on the liver.
It is. However, if the patient survives that initial acute phase, the long-term prognosis is actually favorable.
Really? Why?
Because the adult immune system mounts a vigorous defense against the hepatitis B virus. And once the immune system clears the HBV, the hepatitis B surface antigen disappears.
Oh, I see. When the HBS ag factory shuts down, the hepatitis D virus has no way to package itself.
Exactly. It effectively goes extinct within the patient. The co-infection typically resolves.
But the second scenario, superinfection, that is where this virus becomes a nightmare.
Superinfection happens when the hepatitis D virus infects an individual who is already a chronic carrier of hepatitis B.
So this patient already has millions of hepatocytes churning out massive quantities of surface antigen.
Right. When the Delta agent enters this environment, it finds an infinite supply of vehicles waiting to be hijacked. It goes into absolute overdrive.
And the patient's immune system, as we discussed, is likely in a state of exhaustion or ineffective chronic battling. It's unable to clear the underlying HBV.
Consequently, superinfection leads to chronic infection of both viruses in roughly 90% of cases.
90%?
Yes. This combination is perhaps the most devastating viral disease of the liver.
Because you've got two sources of rust now.
The chronic presence of HGV rapidly accelerates the fibrotic process. Patients progress to advanced cirrhosis much faster, and their risk of hepatocellular carcinoma skyrockets.
So if I am a public health officer or a physician working in a high-risk area, how does the existence of hepatitis D alter my surveillance strategy? Because you can't just test for it randomly. You have to know who is vulnerable.
The epidemiology of HDV forces targeted surveillance. Its global distribution is highly specific and often localized.
Like where?
It is highly endemic in regions like the Western Amazon Basin in South America, specific areas of Central Africa, parts of the Mediterranean, and parts of Eastern Europe.
Okay, so if you're in those regions,
The absolute clinical rule in these regions, or when treating migrants from these regions, is that every single patient identified as a hepatitis B carrier must be actively screened for the Delta agent.
you test for the anti-HDV antibodies, the IgG and IgM.
Yes. You cannot make the assumption that a chronic HBV patient is only dealing with one virus.
Because discovering a superinfection fundamentally alters the clinical hazard profile.
It does. The patient requires much more aggressive monitoring for rapid decompensation, and the treatment options, which historically have been limited to prolonged courses of interferon with poor response rates, are incredibly challenging.
It's a terrifying synergy. But while hepatitis D requires a helper to cause its destruction, there is another virus, one that wasn't even formally identified until 1989, that operates entirely alone.
Right, the viral time bomb.
Exactly. Let's transition to hepatitis C.
Hepatitis C is caused by an enveloped, single-stranded RNA virus belonging to the Flaviviridae family.
And the global footprint is staggering, isn't it?
Yeah. We are looking at an estimated 150 million people chronically infected worldwide, leading to over 350,000 deaths annually from cirrhosis and liver cancer.
And it's primarily a bloodborne pathogen, transmitted through injectable drug use, unsafe medical and surgical procedures.
And historically, blood transfusions before widespread screening was implemented in the early 90s.
Okay, so we just discussed the miracle of the hepatitis B vaccine. But despite decades of research and billions of dollars in funding, we still do not have a vaccine for hepatitis C.
We don't.
The virus entirely evades our attempts to immunize against it. Why? What is this virus doing differently?
The answer lies deep within its replication machinery. Because HCV is an RNA virus, it uses an RNA-dependent RNA polymerase to copy its genome.
Okay.
But this polymerase is remarkably error-prone. It completely lacks a proofreading mechanism.
So it makes typos.
When human cells copy DNA, there are enzymes that double-check the work and fix typos. Hepatitis C has no such system. It makes mistakes constantly,
So it is constantly mutating as it reproduces.
at an astonishing rate. This high mutation rate means the virus does not exist as a single uniform clone. It exists as a massive swarm of closely related but genetically distinct variants.
And in virology, we call this a quasi-species.
Yes. This heterogeneity exists on a global level, which is why we have classified 6 major HCV genotypes and over 100 subtypes. But incredibly, this quasi-species swarm exists within a single infected host.
That is mind-bending. The virus replicating in a patient's liver on Tuesday is genetically slightly different from the virus that was replicating the previous Friday.
And that moving target is exactly why the immune system ultimately fails and why a vaccine is so difficult to design.
Right.
The host's B cells will identify the viral envelope proteins and painstakingly design specific antibodies to neutralize them.
But by the time those antibodies are deployed into the bloodstream.
No, the virus has mutated its envelope structure just enough that the antibodies no longer recognize it. The virus constantly changes its disguise.
It's like a bank robber who slips into an alleyway and changes their jacket every time the police get a description.
That's a perfect analogy.
But what makes hepatitis C even more complex is that the damage isn't confined to the liver. This virus causes profound extrahepatic manifestations. It acts as a systemic immune disruptor.
And this is a vital area of clinical pattern recognition. The human body does not ignore the hepatitis C virus. It mounts a massive, continuous, but ultimately frustrated humoral and cellular immune response.
Because it's chasing that moving target.
Exactly. Over decades, this chronic immune hyperstimulation causes systemic chaos, particularly provoking profound dysfunction in the B lymphocytes, the very cells trying to produce the antibodies.
The text highlights the concept of molecular mimicry. How does that play into the extrahepatic damage?
Well, some of the viral polyproteins produced by hepatitis C structurally resemble normal human autoantigens.
Oh, so the body gets confused.
Right, the confused hyperactive immune system begins to cross-react, producing autoantibodies that attack the body's own tissues. The most classic and severe manifestation of this is HCV-related cryoglobulinemia.
Let's clarify what that actually looks like for a patient.
Cryoglobulins are abnormal immune complexes, clumps of antibodies, that precipitate or physically gel together in the blood when the body temperature drops in the extremities.
Like in the fingers and toes.
Yes, these large protein clumps circulate and lodge themselves into small blood vessels, causing severe inflammation known as vasculitis.
So clinically, what are we seeing?
A patient will present with purpura, distinct purple spots on their legs and skin. They will develop peripheral neuropathy, feeling numbness and burning in their nerves.
And it damages the kidneys too, right?
Dangerously so. These complexes clog the filtering system in the kidneys, causing glomerulonephritis.
It is a total systemic breakdown. And the downstream effects include a significantly higher risk of developing B-cell non-Hodgkin lymphoma.
Driven by that constant B-cell hyperstimulation.
Right. And severe insulin resistance.
The insulin resistance is particularly insidious because it accelerates the progression of the liver disease.
How does it do that?
The virus interferes with the insulin signaling pathways inside the hepatocytes, leading to a specific type of fatty liver disease. And we know that diabetes and insulin resistance independently increase the risk of hepatocellular carcinoma.
So the virus essentially creates a metabolic environment that ensures the liver's destruction.
Exactly.
We are painting a very bleak picture of this virus. But we have to talk about the treatment revolution, because the story of hepatitis C pharmacology over the last decade is one of the greatest triumphs of modern medicine.
It really is.
We have transitioned from a brutal, imprecise therapy to a highly targeted cure.
Historically, the standard of care was pegylated interferon combined with an antiviral called ribavirin.
And as we noted with HBV, interferon therapy is agonizing for the patient.
And depending on the specific genotype of the hepatitis C virus, this grueling year-long therapy only successfully cured the patient 50 to 80% of the time.
It was a coin toss with terrible side effects.
But then came the DAAs, direct-acting antivirals.
DAAs fundamentally changed hepatology.
Completely. These are drugs targeting specific non-structural proteins of the virus. Initially, protease inhibitors like boceprevir and tenofovir, and subsequently highly potent polymerase and NS5A inhibitors like sofosbuvir and lidipasvir.
And they don't rely on stimulating the immune system, right?
No, they dive directly into the hepatocyte and chemically jam the specific viral enzymes required for replication.
And the terminology we use to define success changes here. With hepatitis B, because of that hidden cccDNA, we talk about viral suppression. With hepatitis C, the target is SVR, sustained viral response.
And SCR is the functional equivalent of a total cure.
Wow.
If a patient completes their course of oral DAAs, which now often takes only 8 to 12 weeks with minimal side effects, and their blood tests remain entirely negative for HCV or RNA 12 weeks after finishing the medication, they have achieved SVR.
Because hepatitis C does not form cccDNA.
Exactly. It does not archive itself in the nucleus. Once the RNA is cleared from the cytoplasm, the virus is eradicated.
It is a pharmaceutical miracle. But the existence of a cure does not automatically erase the public health burden, because the system's impact of this virus runs incredibly deep.
The structural barriers are huge.
Yeah. I want to examine a striking historical anomaly discussed in the literature that perfectly illustrates how public health policy can inadvertently fuel a pandemic: the massive hepatitis C epidemic in Egypt.
The Egyptian HCV epidemic is one of the most profound epidemiological tragedies of the 20th century.
The numbers are just wild.
By the late 90s and early 2000s, demographic surveys revealed that in specific areas, particularly the Nile Delta, the seroprevalence of hepatitis C antibodies in older adults was approaching an astonishing 60%.
Let's pause on that. 60%. Hepatitis C is a blood-borne pathogen. How does a virus transmitted by blood infect 60% of an entire demographic?
It wasn't driven by intravenous drug use.
Right. So what was it?
It was entirely iatrogenic, meaning it was caused by medical treatment. To understand it, we have to go back to the mid-20th century. Egypt was facing a massive, debilitating endemic crisis of schistosomiasis, a parasitic flatworm transmitted by freshwater snails in the agricultural canals.
It caused severe bladder and liver disease.
Right. The public health authorities, acting with the best of intentions to save their population, launched massive nationwide parenteral therapy campaigns.
Parenteral meaning they were treating the parasite with mass injections.
Specifically, intravenous injections of tortiremetic. Millions of doses were administered over decades.
Okay.
But this occurred before the virus was discovered and, critically, before the rigorous implementation of single-use disposable syringes.
Oh, no.
The medical teams used reusable glass syringes and needles. They would often just dip them in boiling water or use inadequate chemical sterilization between patients.
And boiling water does not consistently destroy a hardy virus like hepatitis C.
Exactly. The clinics treating the parasite became incredibly efficient viral vectors. A single contaminated needle could infect dozens of people in a single afternoon.
By trying to eradicate a parasite, the healthcare system inadvertently seeded a viral time bomb across multiple generations.
It is a devastating reminder of the core public health mantra: first, do no harm.
And it reinforces why, in the absence of a vaccine, our primary interventions against HCV must be structural.
Right. It requires the unyielding enforcement of safe injection practices, the meticulous screening of the global blood supply,
And the implementation of needle exchange programs for intravenous drug users to stop the transmission at the source.
And while the DAAs can cure the virus, the current public health bottleneck is purely logistical and economic. We have to identify the millions of asymptomatic carriers through mass screening programs.
And secure the funding to provide them with the medication before their liver reaches the point of decompensated cirrhosis.
Exactly.
We have spent the first half of this deep dive exploring viral invaders, pathogens that attack us from the outside. But there's an entirely different category of liver destruction, one driven by substances we willingly consume. Let's shift our framework from infectious disease to toxicology and metabolism. We are moving into alcoholic liver disease.
Alcohol consumption is inextricably woven into the social fabric of most human cultures. But from a purely epidemiological standpoint, the burden it places on global health infrastructure is staggering.
It really is.
Alcohol is responsible for roughly 2.5 million deaths annually, accounting for 5.5% of the global disease burden.
And in regions like Europe, alcohol is the leading indication for liver transplantation, responsible for 37% of cases independently.
And acting as a contributing cofactor in over 50% of all cirrhosis-related transplants.
It is a massive, visible, and entirely preventable hazard. But we need to look under the hood. How does ethanol actually dismantle the structural integrity of the liver? Walk us through the pathology sequence.
The destruction follows a distinct progressive timeline. The first, almost universal physiological response to heavy alcohol consumption is macrovesicular steatosis.
This is fatty liver.
Yes. As the liver metabolizes ethanol, it shifts its biochemical priorities, leading to the massive accumulation of large fat droplets inside the hepatocytes. The liver physically swells with fat.
And a crucial distinction to make here is incidence versus prevalence and reversibility. If a patient is diagnosed with simple steatosis, their liver isn't permanently doomed, right?
Steatosis is entirely reversible. If the patient achieves complete abstinence from alcohol, the fat mobilization normalizes, and the steatosis can resolve entirely within 2 to 4 weeks.
That's pretty fast.
It is. However, we used to view fatty liver as a completely benign condition. We now know from longitudinal studies that 5 to 15% of patients with simple alcoholic steatosis will silently progress to cirrhosis over a 10-year period, even without obvious intermediate inflammation.
But for many, that intermediate inflammation does occur. That is the next step, alcoholic steatohepatitis, or ASH.
And this is where the true cellular injury begins. The hepatocytes undergo ballooning degeneration, meaning they physically swell and become damaged.
You see the formation of Mallory Bank bodies, right?
Yes, which are tangled clumps of damaged structural proteins inside the cells. Most importantly, you see an aggressive infiltration of inflammatory immune cells, specifically polymorphin nuclear neutrophils, swarming the liver tissue.
So the immune system reacts to the toxic injury, causing massive inflammation.
And that inflammation stimulates the hepatic stellate cells to start laying down scar tissue. You get a very specific pattern of paravenular and paracellular fibrosis, often described as looking like chicken wire under the microscope.
Over years, this thickens into nodules, the architecture of the liver is destroyed, and you reach end-stage cirrhosis, paving the way for portal hypertension and hepatocellular carcinoma.
That's the progression.
But here is where the epidemiology gets fascinating, because the dose-response matrix is not equal for everyone. You can have two people drinking the exact same amount of alcohol, but the risk of developing cirrhosis is vastly different.
Very true.
The literature makes a strong point about gender disparity. Women are significantly more susceptible to alcoholic liver disease at much lower doses than men.
The clinical thresholds highlight this clearly. The risk of severe liver damage increases significantly at a consumption level of 60 to 80 grams of alcohol per day for men. For women, that threshold is drastically lower, just 20 to 40 grams a day.
The easy assumption is that this is simply due to body mass and total water volume. Women are generally smaller, so the concentration is higher, but the mechanism goes much deeper than that, doesn't it?
What's fascinating here is that body mass plays a role, as does the fact that women have lower levels of gastric alcohol dehydrogenase.
The enzyme in the stomach that breaks down a fraction of the alcohol before it ever reaches the bloodstream.
Right. Because of this, a higher proportion of intact ethanol reaches a woman's liver. But the most profound mechanism driving this disparity is hormonal. It involves the gut-liver axis.
This is a phenomenal physiological mechanism. Explain the role of estrogen in liver toxicity.
Well, the liver does not exist in isolation. It receives the entirety of the blood flowing directly from the intestines via the portal vein. The human gut is lined with trillions of bacteria. The cell walls of many of these bacteria contain a highly inflammatory molecule called endotoxin, or lipopolysaccharide, LPS.
And normally, the gut lining acts as a strict barrier, keeping that endotoxin inside the intestine.
But alcohol damages that barrier.
It does.
However, biological evidence suggests that estrogen acts as a massive multiplier for this damage. Estrogen significantly increases the permeability of the gut lining, specifically in the presence of alcohol.
It makes the gut much leakier.
Yes. So a woman drinking alcohol will have a much higher surge of bacterial endotoxin leaking into her portal blood and traveling straight to the liver.
And how does the liver react to that surge of bacterial debris?
It reacts violently. The liver is guarded by resident immune macrophages called Kupffer cells. Estrogen not only increases the amount of endotoxin arriving, but it also upregulates the specific receptors, CD14, on the surface of those Kupffer cells.
It makes the immune guards hypersensitive. So you have a massive influx of inflammatory triggers hitting immune cells that have been primed with a hair trigger.
When the endotoxin binds to those sensitized Kupffer cells, they activate and flood the liver with pro-inflammatory cytokines, specifically tumor necrosis factor alpha, TNF-alpha.
And it is this...
It is tempting to isolate compounds like resveratrol or other antioxidants in red wine and attribute protective cellular effects to them. And while in vitro studies might show some antioxidant activity, the population-level reality is much more complex.
It's the correlation versus causation trap.
Precisely. In many Western societies, the choice of alcoholic beverage is deeply tied to socioeconomic status, dietary patterns, and overall health behaviors.
So it's not the wine, it's the lifestyle of the wine drinker.
Statistically, individuals who consume wine in moderation often have higher incomes, better access to health care, and critically, they are more likely to consume a Mediterranean-style diet rich in fruits, vegetables, and lean proteins while avoiding highly processed foods.
So the wine might just be a surrogate marker for a life that is otherwise highly protective of the liver.
The current consensus leans heavily toward the lifestyle factors rather than the specific beverage. Furthermore, the pattern of drinking is paramount.
Binge drinking aspect.
Yes. Consuming alcohol outside of meals or engaging in binge drinking, consuming large quantities in a short time frame, massively overwhelms the liver's metabolic capacity and increases the risk of alcoholic hepatitis fivefold, regardless of whether it's wine, beer, or spirits.
We consume alcohol fully aware of its toxic potential.
Yeah.
But what happens when the very mechanism of human survival, the food we eat and how we store energy, becomes the driver of liver failure?
That is the big question.
This brings us to what is arguably the defining public health crisis of modern hepatology. Let's explore non-alcoholic fatty liver disease, or NAFLD, and its severe counterpart, NASH.
The scale of NAFLD is almost difficult to comprehend. We are observing the accumulation of massive amounts of fat inside the liver, histologically identical to what we see in severe alcoholism, but occurring in patients who consume little to zero alcohol.
And the strict diagnostic threshold requires the patient to consume less than 10 to 20 grams of alcohol per day.
We need to define the nomenclature clearly because the clinical implications are vastly different. Differentiate NAFL from NASH.
NAFL, or non-alcoholic fatty liver, is the presence of simple steatosis. The liver is fatty, but there is no significant hepatocellular injury or widespread inflammation.
The risk of this progressing to cirrhosis is relatively low.
Right. But NASH, however, non-alcoholic steatohepatitis, is the aggressive, progressive phenotype.
In NASH, the fat accumulation is accompanied by the same severe ballooning degeneration of hepatocytes and lobular inflammation that we see in alcoholic hepatitis. NASH is the engine of fibrosis, leading directly to cirrhosis and hepatocellular carcinoma.
And the prevalence of NAFL is entirely tethered to the global shift in diet and lifestyle. It tracks perfectly alongside the epidemics of obesity and type 2 diabetes.
In fact, NAFD is now widely considered the primary hepatic manifestation of metabolic syndrome.
Absolutely, if a listener recalls the ATP3 criteria for metabolic syndrome.
Central or visceral obesity, hypertriglyceridemia, low HDL cholesterol, arterial hypertension, and impaired fasting glucose or frank diabetes.
These are the exact physiological conditions that drive fat into the liver. The peripheral tissues become resistant to insulin, so the body produces more insulin.
And this hyperinsulinemia drives free fatty acids directly into the liver, overloading its capacity to process them.
And the downstream system impact of this metabolic overload has fundamentally rewritten hepatology.
It has. For decades, clinicians would encounter patients with end-stage cirrhosis. And if the patient tested negative for hepatitis B and C and had no history of alcohol abuse, the diagnosis was labeled cryptogenic cirrhosis,
meaning cirrhosis of unknown hidden origin.
We now know that a massive proportion of that cryptogenic cirrhosis was simply end-stage NASH. The fat often actually burns out and disappears from the tissue as the liver becomes completely scarred over, leaving only the cirrhosis behind.
Today, NASH is one of the fastest growing indications for liver transplantation globally, already accounting for over 8% of transplant waitlists in Europe and much higher in the United States.
But this presents a terrifying clinical bottleneck.
Right. If I am a primary care physician managing a patient with obesity and diabetes, I know they likely have a fatty liver. But how do I know if they have benign NAFL or if they have progressive, dangerous NASH?
That's the challenge.
I can order an ultrasound and it will show a bright, fatty liver. But can it show the inflammation?
No, it cannot. Standard imaging, like ultrasound or CT scans, are excellent at detecting the presence of macroscopic fat. They are completely blind to cellular injury, ballooning, and inflammation.
Furthermore, standard liver function tests are highly deceptive, right?
Very. You can have a patient with massive biopsy-proven steatohepatitis and advanced fibrosis who has perfectly normal ALT and AST transaminase levels in their blood.
That is deeply unsettling. Half of the patients with active liver destruction have normal blood tests.
Yes. Because the injury and anaxia can be slow and smoldering, the enzymes don't always leak into the blood in large enough quantities to trigger an alarm.
So what do we do?
Therefore, the absolute, unequivocal gold standard for diagnosing NASH and staging the degree of fibrosis remains an invasive liver biopsy. A pathologist must physically look at the tissue under a microscope.
And that is the crux of the public health failure. We have a global obesity epidemic. In some populations, 25 to 30% of adults meet the criteria for metabolic syndrome.
We cannot perform millions of invasive, expensive liver biopsies, which carry a risk of bleeding and complications, just to screen for NASH.
So how does a health system adapt to this diagnostic void?
We are desperately trying to validate non-invasive biomarkers. The most prominent physical tool is transient elastography, commonly known as a FibroScan.
Okay, how does that work?
It uses ultrasound shear waves to measure the physical stiffness of the liver. A fibrotic, scarred liver is stiffer than a healthy liver. It is becoming an excellent tool for ruling out advanced cirrhosis without a biopsy.
But it still lacks the perfect precision to definitively diagnose the intermediate stages of NASH inflammation.
Exactly. Which means the ultimate public health strategy cannot wait for perfect diagnostics. The intervention must target the root cause, the metabolic syndrome itself.
Right. The primary treatment for NASH is intensive lifestyle modification, caloric restriction, sustained weight loss, and exercise. Losing just 7 to 10% of total body weight can dramatically reduce liver inflammation and even regress early fibrosis.
But sustained weight loss is incredibly difficult to achieve at a population level. Bariatric surgery has shown phenomenal results in resolving NASH, and it is strongly indicated for patients with a BMI over 40 or over 35 with severe comorbidities.
But surgery cannot be the primary population-level answer.
No. So we turn to pharmacology. But looking at the literature, treating NASH with drugs seems like walking a therapeutic tightrope.
The text discusses targeting the insulin resistance with drugs like pioglitazone, or targeting the oxidative stress with massive doses of vitamin E.
Both have shown histological efficacy, but both carry significant caveats. Pioglitazone is a thiazolidinedione. It improves insulin sensitivity and has been shown in trials to be superior to metformin in improving the actual liver histology in NASH-Air patients.
But its systemic side effects include weight gain, fluid retention leading to potential heart failure exacerbations, and an ongoing debate about an association with bladder cancer.
You are balancing the risk of liver failure against the risk of heart failure.
It requires meticulous patient selection. And vitamin E, an antioxidant, has shown documented amelioration in liver pathology for non-diabetic NASH-Air patients.
But prolonged high-dose vitamin E supplementation is not benign. It has been associated in large trials with a slight but significant increase in the risk of hemorrhagic stroke and an increased risk of prostate cancer in men.
There is no magic bullet. You cannot chemically out-medicate an environment that constantly drives metabolic dysfunction.
The treatment for NFLD and NASH has to be systemic, multidisciplinary, and heavily focused on the environmental and dietary drivers of the disease.
We have covered an immense landscape today, mapping the architecture of chronic liver disease, from viral DNA to human metabolism. Let's synthesize our key takeaways to solidify these frameworks.
Summarizing the evidence objectively, chronic hepatitis B and C are massive global drivers of morbidity and mortality. They operate precisely as the silent rust we described, initiating decades of asymptomatic damage that inevitably leads to cirrhosis and hepatocellular carcinoma.
Our interventions must match the biology. For hepatitis B, because the virus finds within the nucleus as cccDNA, our greatest weapon is universal infant vaccination, preventing the high-risk perinatal exposure that drives chronicity.
For hepatitis C, the rapid mutation of its quasi-species genome prevents vaccine development, but the advent of direct-acting antivirals allows us to functionally cure the infection by shutting down its replication machinery.
And across all these bloodborne pathogens, aggressive harm reduction, stringent blood supply screening, and unyielding safe injection practices are the bedrock of global elimination strategies.
Finally, as we look to the future, alcoholic and non-alcoholic fatty liver diseases represent massive, accelerating burdens. They are deeply intertwined with socioeconomic factors, gender-specific endocrinology, and the global crisis of metabolic syndrome.
And this leads us to a profound, overarching reality about the trajectory of global hepatology.
It does.
I want to leave you, the listener, with a final thought to mull over. We are currently witnessing a historic transition. As global health systems slowly but successfully harness antivirals to eradicate hepatitis C, and as generations of universal vaccination programs suppress the prevalence of hepatitis B, the viral threats are receding.
But nature abhors a vacuum.
NASH is rapidly climbing the ranks, poised to take the throne as the undisputed king of chronic liver disease in the 21st century. The question we must grapple with is this: are our modern global healthcare systems, which were fundamentally designed and funded in the 20th century to identify and combat transmissible infectious pathogens, actually equipped to handle a massive, relentless tsunami of end-stage organ failure that is driven almost entirely by the modern global food environment and sedentary lifestyle.
It requires a paradigm shift from fighting an external pathogen to treating a systemic, environmentally driven metabolic collapse. It will test the limits of our medical infrastructure.
Absolutely. Okay, let's lock in this conceptual framework. We're going to move into our learning reinforcement segment. I will propose a clinical scenario or a mechanistic question, tell you to take a second so you can mentally formulate the answer, and then our expert will provide the resolution and point you back to the specific conceptual area of the Oxford text to review. Ready? Let's begin. Prompt 1. A junior doctor is managing a young patient chronically infected with hepatitis B. The attending physician notes that the virus itself is not directly cytopathic. What then is the primary biological mechanism responsible for the necroinflammation and hepatocellular injury driving the patient's disease? Take a second to think about it.
The injury is caused by the host's own immune system activation. Specifically, during the immune clearance phase, the host's cytotoxic T cells recognize viral antigens on the hepatocytes and attack the infected cells. Review the HBV clinical manifestations section for consolidation of these phases.
Prompt 2. Let's look at epidemiology. What is the single most important variable that distinguishes the virological outcome of an individual acquiring hepatitis B in the perinatal period versus acquiring it as an adult? Take a second.
The age of exposure dictates the chronicity. Perinatal infection carries a 70 to 90% risk of developing chronic infection due to the immature immune system's tolerance. In contrast, adult infection resolves and clears the virus in over 95% of cases due to immediate immune clearance. Review the HBV transmission section.
Prompt 3. A patient with a known history of chronic hepatitis B suddenly presents with severe acute decompensating hepatitis. Serological testing reveals a new copathogen that relies on a unique rolling circle RNA mechanism. What specific viral infection has occurred, and what is the statistical likelihood of chronicity for this new pathogen? I'll give you a second.
The patient has experienced a hepatitis D superinfection. Because the Delta agent has an endless supply of existing HBs ag to utilize, this leads to chronic HDV infection in approximately 90% of cases, rapidly accelerating liver failure. Review the hepatitis D section.
Prompt 4. From the perspective of a pharmaceutical researcher, why has the development of a preventative vaccine for hepatitis C proven nearly impossible compared to the highly successful vaccine for hepatitis B? Take a moment to formulate your answer.
Hepatitis C utilizes an RNA polymerase that lacks proofreading ability, causing rapid mutation. The virus therefore exists as a highly mutable quasi-species swarm even within a single host, making it a constantly shifting target that evades long-term neutralizing antibodies. Review the HCV etiological agent section.
Prompt 5. A female patient in a primary care clinic asks why she appears to be more susceptible to developing alcoholic liver disease at lower consumption volumes than her male counterparts. Beyond differences in body mass and gastric enzymes, what specific hormonal and immunological mechanism drives this risk? Take a second to think about that axis we discussed.
Estrogen significantly increases gut permeability to bacterial endotoxins, the LPS, and upregulates the CD14 endotoxin receptors on the liver's Kupffer cells. This leads to an exaggerated hyperinflammatory release of TNF-alpha in the liver. Review the alcoholic liver disease risk factor section.
Prompt 6. A 50-year-old patient with central obesity and diabetes undergoes an ultrasound that reveals a bright, fatty liver, indicating macrovesicular steatosis. To definitively diagnose progressive, non-alcoholic steatohepatitis, NASH, rather than benign simple steatosis, what pathological features must be demonstrated, and what is the only gold standard test to see them? I'll give you a second.
The diagnosis of NASH requires the histological demonstration of hepatocellular injury, specifically ballooning degeneration and lobular inflammation. Because imaging and blood tests are inadequate for seeing this inflammation, the definitive gold standard test remains an invasive liver biopsy. Review the NAFLD and NASH diagnosis section.
Keep the structural metaphor in mind as you study. The liver is the foundation of the biological city. Don't let the silent rust go unnoticed until the bridge collapses.